all. Today, on behalf of Dr. Ashok Ved, we are here to present Oncology Masterclass on head and neck cancers. Dr. Ashok Ved is a Padma Shri awardee for his contribution to medicines. He is a chairman, Medical Oncology and Hematology Medanta, the Medicity in Delhi. Now let us begin with our first speaker. With pleasure, I would like to invite Dr. Shruti Behal, DM Medical Oncology, Max Nanavati Hospital, Mumbai. She is going to speak on multi-omic profiling in head and neck cancer, clinical applications. Yes, over to you, Dr. Shruti Behal.
Hi, thank you for having me here. Can you share my slides? These are not my slides. These are not the slides.
Okay, one second. Dr. Shruti slides, Om Mishra has mailed me this only. I got this one only.
Okay.
Multi-omic profiling in head and neck cancer.
Yes, but actually with this thing, I had yeah.
Yes, this is the topic, no?
Yeah, this is the topic, but the slides are not those ones. So, can we just try screen sharing for one last time? Otherwise, I'll use that.
Okay.
Can we try?
Okay, wait.
Otherwise,
Yes.
Yes, I'm doing that. I'm trying. Yes. Is it visible? Just a moment. I think so. It will share now. It's showing the. Can you see multi-omic profiling in head and neck?
Yes, ma'am. It is visible.
And my slide. Okay. So good evening, everyone. So here I'm going to talk about multi-omic profiling in head and neck cancer and its clinical applications. So multi-omic profiling, the concept and where do we stand today? It is a study of interaction of all the biological functions within the cell and with other body functions. We combine this data with targeted tests and the global assays that we have in today's world genomic sequencing with our patient-specific information. Integrating these multi-omic data analysis with machine learning, we want to discover new biomarkers enabling comprehensive characterization of molecular alterations. This would help us to provide disease subclassification to guide treatment decisions and analysis of key mechanisms for what causes cancer, for the functional consequences, the drug resistance, and the disease progression. So omic data in oncology, what are the types of data? We all are aware of the well-established data in clinical practice, that is genomics, which include point mutation, insertions, amplifications, deletions. Established in clinical practice is also the transcriptomics, which is the expression of the genes, the gene fusion, the slice variants. There is significant research upcoming for epigenomics, where we are studying about reversible modifications of the DNA or the DNA-associated proteins, such as the methylation or histone acetylation. The research now is increasing going towards proteomics, which is the study for peptide abundance, the modifications, and the interactions, and going down more in the molecular level, now emerging data to the metabolomics, that is the amino acids, fatty acids, carbohydrates, and other products and of cellular function. So this is a German study which was done, which is comprehensive genomic transcriptomic analysis done in Germany. It was a multicentric trial which was observational prospective. They had taken around 230 patients, out of which 1,300 could reach the multidisciplinary tumor board, out of which only 27 patients got treatment implemented according to the molecular tumor board and their molecular analysis. They took around 472 genes, divided it into 6 baskets, which included immunoinvasion, DNA damage repair, the PIK3 AKT mTOR pathway, the RAF MERK pathway, tyrosine kinase pathway, the cell cycle pathway. Some new developmental regulation baskets were there, and others which did not fit into these. And then the patients were given the particular drugs and enrolled into the clinical trial. So the guidance of treatment decisions was made basically on the genomics and the transcriptomics, and they included the alterations of each tumor type was according to its single gene variant, the fusion, the gain and overexpression, deletion or underexpression in each particular tumor type. And the relative contribution of biomarkers was studied across various tumors. For treatment decisions, having a good common endpoint to know the benefit, the clinical benefit of this decision, it was intra-patient. So the progression-free survival from a molecularly informed therapy, that is PFS2, was divided by PFS1, that was the progression-free survival on standard therapy. And it was considered significant if it was more than 1.3-fold and as a ratio. And if we see in this cartoon over here, the head neck, at least 50% of the patients had more than 1.5-fold increase in the PFS. If their decision making was based on the molecular information and the pathways, then on standard therapies. Similar studies we have in 2018, in which there is this Berlin-1 biomarker analysis is a similar study emphasizing the same. Here they had taken recurrent head neck cancer patients who had PIK3-PTEN mutation activation in few tumors and not. And they came to, if you see in the cartoon, you will see the dotted lines are the patients who had a PIK3 activated mutation, while the solid lines are those who were non-activated, but there was no significant difference in their median OS. So hence, this proved that that PIK3 mutation, though we are using abrubacip, which is a pan PIK3 inhibitor, did not really affect the outcome of the patient, and other factors like P53 alterations, HPV status negative, low mutational burden, or high infiltration was more contributory for a survival benefit. Similar studies was done in 2018, in which the outcome of pembrolizumab on tumor mutational burden and T-cell inflamed gene expression was seen, in which patients who were non-responders were the ones who were basically with a low tumor mutational burden or gene expression profiling. As you can see in the graph, where the red line, the OS is very less than the blue. So ongoing clinical research initiatives is ImmunoCAN. These are trials which are going, they're integrating immunoprofiling of large adaptive cancer patient cohorts. Around 300 cancer patients are included, including they are integrating the profiling data of the molecule with the clinical data, focusing on multiple cancers, including head neck. And their aim is to develop a sustainable platform and a legal framework where the partners in the study can pursue their own independent investigations and support that for future use for data generation by project and by research community. The integration, there are further researches which are basically focusing on proteomics, the metabolomics with AI, AI data management, which will aim to predict the success of treatment, to improve management and prescription or oncology, to understand mechanism of treatment resistant, where head neck as a main clinical use, and a thorough output of the proteomics for low mutational samples. There is a silicon model which is also coming up with newer common endpoints to validate these studies, to validate genomic signatures in head neck cancer outcome and treatment response, to develop treatment decision, to support tools, and to test acceptability of these omics data-driven research for drawing new ethical and regulatory frameworks. So the take-home message is this is obviously going in the more molecular and the more pathway related profiling to treat cancer in a totally different way from where we have come from histopathology, and to guide treatment using these genomic, transcriptomics, epigenomics in head neck cancer, selecting patients who will do benefit with better with PD-L1, tissue of origin analysis, and disease subclassification. And additionally, what we require is translational and clinical research efforts are needed to validate the candidate predictive composite biomarkers, signature derived from multi-omics profiling studies, and to integrate them into treatment decision and support tools. So this is, thank you. Yeah.
Thank you so much, Dr. Shruti Bahel. Now, I would like to invite Dr. Satish CT, Senior Consultant at CG Hospital in Bangalore, and he is going to speak on circulating biomarker assay in individualizing targeted therapy and IO for head and neck cancer, ctDNA. Thank you. Over to you, sir.
Yeah, good evening. I thank Dr. Ashok Vaid sir to give me opportunity for today's presentation. My slides are visible.
Yes, sir.
Yes, sir.
Yes, sir. I'm going to talk about this one of the paper presentation done in the ESMO 2022 recently, like circulating biomarker assay, like to go for the individualizing the targeted therapy in head and neck cancer. Let me go through this presentation. I think this is like why outline of my presentation, introduction about the circulated biomarker, and try to concentrate towards the cell-free DNA, how we are going to individualize our target therapy in general, and other than what Shruti has said, actually, like based on the cell-free DNA based targeting therapy, and also IO based, especially in the recurrent and metastatic head and neck cancer, and locally like advanced head and neck cancer. Coming to the introduction, we know that when you're going for cancer, we may do the certain cancer, we do screening method, and we'll try to diagnose a certain couple of cancers. We are having the screening method like to detect early, but we don't have a, like the even though head and neck cancer we can do visually in early pre-cancer lesion we can do, but we cannot have a like how we do breast cancer and the HPV like CSR weeks and colon. We don't have that effective method. This still is investigational. A lot of changes is advances happen in our oncology, like we try to go for a screening diagnostic method and we try to see the biology of the disease individually with the multiple sites and multiple biology of the disease in each site. Also we try to see determine the prognosis and monitoring of the what the treatment advances happened recently immune based treatment, immune checkpoint inhibitor, and try to assess how best they are responding and try to titrate the response to treatment and risk-based treatment, risk stratification we try to do. So much of advances happening in the our like oncological field. When it coming to the circulated DNA cells, like you can DNA like you that from that one DNA we try to analyze it, what are the mutation analysis, what are the newer changes happening in our cancer cells. You can see that like this is a picture you can depicting you can cancer cells once they're releasing into it, when their cells are dying and when they're circulating cells also, that contribute the component of the cell-free DNA. But one thing is that like it can be contributed from the cancer cells and also necrosis and apoptosis of the normal cells also done in aggressive inflammatory cells also. You can have dying cells like you can come in a picture. This is one of the challenges. That one thing is there, once you identify the cancer specific DNA, you can try to go for a somatic alteration. You can see that is one of the advantage without going for a the invasive technology of the biopsy and those things. You can monitor this, and let me go through the next coming slides. The challenges what we face here is the low yield of the selfie DNA, and also like the difficult task of differentiating from the selfie DNA from the like what we have seen that a tumor from the background knows what I said about the healthy cells and necrotic cells when they're selling, when the cells are dying, that they can contribute to this. Difficult to differentiate with the normal cell-free DNA. Like there are technologies to identify based on the wavelength length that does the specific mutation of this one. We are able to tell it is a cell tumor related cell-free DNA and those things. But you have to overcome what are the technology has improved to overcome all those things. We should be have a the the lab should have a very accredited to do this identify all those things. Coming to this lot of advanced in technology to sequence what is the selfie DNA analysis, and also like it can be single mutation or limited multiplex panel. The beaming it is not used in our like setup. Digital droplet PCR method is one of these. It is going to is very like lesser amount also you can able to pick up this one self like a digital DT-PCR. There's a one thing is followed in our institutions of various institutions over India and many institutions globally also. There is a very easy to in a short span you can able to pick up the thing with a limited like in the small quantity also you can able to quantify that. That's one advantage. But it should be like example is like a EGFR mutation in lung cancer. You can able to monitor the response treatment and even resistant mutation you can able to pick up in this. That's one thing. That if you're going for the that some more panel of the target like a couple of group of cancer, you can have a lung cancer panel, colorectal cancer like that, like a head and neck cancer. We like you can go for the ingest technique and in a sub specification of the ingest technique, all those things. They try to go for the advance in the improvement in the sequencing method and the compared to the older technology now hybrid capture technology try to pick up the even like exosome sequencing, all those will try to have a more wider coverage actually when they're going for the advanced like when you're going for these whole exome and whole exome like a genomic sequence, it is time consuming, is a there's a costing huge actually the cost actually. But one thing going for the like academic thing interest and in investigation in the clinical trial they'll try to go for this one. Generally clinical practical utilization will try to go for either single or targeted panel genome will try to go. Coming to the that it can be the selfie DNA when you're going for a somatic analysis you can go for, it can be tumor informed, it can be tumor agnostic. Tumor like it can be like what are the specific alteration is there that can be utilized for the marker for the selfie like selfie DNA tumor specific DNA in presence of personalized panel for that same patient. It can be that monitoring for the sequence and availability and the only thing is the very limited you may not able to detect as a one thing, and also you can miss the new emerging the clones all those things. If you are customized for that patient, actually you have to see that any newer mutation. This is the tumor like a patient specific actually that the tumor informed what are the mutation marked is seen in the beginning. This is helpful for the MRD but not for the newer mutation. But when the limitation is there, you no limit, you cannot able to pick up what are the technology you are using. Tumor agnostic, we have to go a little bit more the sequencing actually that Guardant also is there, another thing cap sequencing actually. Here the tumor not specific, but you have the good number of wide coverage of the mutations will be picked up here. The only thing the background analysis of the chip mutation is a little bit confusing. You should be well versed with how to read about this the somatic mutations of those things. Come the what are the common thing actually, and also is a advantage is there to detect the new emerging clones. Coming to the how cell-free DNA are going to individualize the target therapy in head and neck and oral IO therapy, especially in the recurrent and metastatic head and neck cancer. It will be helpful for the monitoring the response to treatment and also identify the certain target in based on the what are somatic mutation you are going to heal from that cell-free DNA, and also you can identify the resistant to the what are ongoing treatment. Coming to this is the slide depicting is the HPV positive head and neck cancer. We can see the monitor the response like you can see here is one of the observation study what is depicted here. Immune response treatment here like you can see here how the treatment is helping actually in a different individual. What was the previous value and how it is trying to have a lowering the value. Cytotoxic chemo agent also is a various subject you try to have a difference in from the baseline to the subsequent ongoing treatment. You can see that how the levels are like distributed actually. During progression, you can see here the levels was the lower level that is trying to increase, and this is the thing like our club days like it's a newer thing that
Um, I think so. Is there any problem?
Dr. Satish, sir?
Yeah, yeah. It abruptly stopped.
Yeah. So, Priyanshi, you can invite the next speaker. I hope Dr. Srinivas is ready.
I
Dr.
am ready.
Srinivas?
Yeah, I'm ready, sir.
Thank you so much.
Um, Dr. Srinivas Vijay is a consultant medical oncologist in HCG Hospital, Bangalore, and he's going to speak on new promising targets on the horizons HRAS, PI3KCA, NTRK, RET, NOTCH1, BRAF. Over to you, sir. Thank you.
Yeah, just will share my slides.
To stop share.
So it is coming. You cannot start screen share while the other participant is sharing. Yeah. Good evening, everyone. So this is also one of the ESMO presentation by Professor Christopher in ESMO recently conducted, and I was lucky enough to attend this session as well. Physically, I was there in this session. So this is about the new promising targets on the horizon in head and neck cancers. So usually the EGFR mutations, EGFR expression we have seen. So this is one of the trial, extreme trial, where the platinum plus 5FU plus cetuximab versus only chemotherapy alone in a metastatic or locally advanced recurrent head and neck cancer they have tested, and they have seen that there was a PFS and OS benefit around 3 to 3.5 months. So this was published in 2018. So cetuximab monoclonal antibody so then has become a standard of care with addition to the chemotherapy, platinum 5FU combination. So in one of the subgroup of this trial was EGFR expression. So EGFR expression was is seen almost 80% of the patients, and they have seen that EGFR expression less than 40 and more than 40% they have seen, and they have more than 40% have there is a subgroup benefit with a confidence interval within one with a good hazard ratio compared to the patients with less than 40% of EGFR expression, which is we do it in a IHC basis. So EGFR, almost 80% of the patients we do see in the head and neck cancers. So based on this, they have done a retrospective analysis in 2011. So where they have done the archival tumor tissue, the same group, cetuximab plus chemotherapy patients, they have done the amplification. That is, fish studies they have seen, and they have quantified the how much is the amplification depending upon the different criteria, and they have classified it to fish positive EGFR and fish negative EGFR, and they found that there is no difference in the patients whether it is a fish positive or fish negative in the cetuximab plus chemotherapy. So overall survival, there was no difference. You can see here hazard ratio is almost crossing 1, 10.5, 10.6 months. Even the PFS, there was no difference, 6.2, 5.7, almost similar. And even the best overall response also, there was no difference. So they have concluded that EGFR amplification or EGFR expression is not a predictive factor. So there is no use of doing this EGFR amplification testing for the head and neck cancer patients to see whether cetuximab works or not. So irrespective of this, the cetuximab works for the most of the patients in head and neck cancer, metastatic or recurrent. So after the EGFR amplification, then the RAS mutations. So here we can see one of the study where when there is a mutation is there. So most of the patient had the wild type is the red type, where the progression-free survival is better compared to the patients which is a blue line. Almost progression-free survival is very poor when the RAS mutation is there. So, this is the session where they have classified into promising targets without companion biomarkers, and promising targets with a companion biomarker, antibody drug conjugates, and so on. So coming to promising targets with a without companion biomarkers. So PI3K mutation is one target. So they have it's usually seen in around 30 to 50% of the patients with head and neck cancer. So here there are the above diagram depicts the xenograft model. They have seen that patients with KRAS mutation. So the Cal33 Detroit is the one where there is a PI3K is not mutated, wild type. The lower two, PCA and ACC9 is the one where there is a PI3K is mutation, and BZ235 is a PI3K inhibitor plus dual PI3K and mTOR inhibitor. So this is the animal model, xenograph model, where they have seen that with the control, the above row is the control, and the red one is the where with after this PI3K and mTOR inhibitor, PI3K mutated tumors have responded very well. Similarly, the lower diagram panel depicts the patient tumor grafts. Tumor grafts planted on the animals where they have done, there is a definitely with BZ, that is dual inhibitor, PI3K and mTOR inhibitor, there is a definite response when there is a PI3K mutation is there. And similarly, in the PI3K wild type is there, so there is no response. So we can see here the control and the PI3K wild type, I mean, BZ treated patients almost similar. Similar. So, and it is positive more in the HPV positive patients. So, based on this trial, they have conducted a trial, Beryl 1 trial, in 2017, which has come out. It is a phase 2 trial, and using the pan PI3K inhibitor. So that is bupralisib plus paclitaxel versus placebo and paclitaxel, and they have seen that there is a progression-free survival improvement, and there is a oral response rate. Almost 31%, 39% compared to 14% in the placebo group. Even the oral survival, there was a significant difference. Only one the promising or the warning side effect was hyperglycemia in this group of patients. So they have seen that, but it is not a predictive of PI3K activation. So here we have a three diagrams depicting the same. So PI3K activation is there or not, whether it is PI3K activated or not activated, there is no difference. But there was a difference in TP53 status and HPV status. So TP53 status is mutated. There is a definite benefit with this drug, bupralisib pan PI3K inhibitor, and even HPV status by archival tumor. They have seen that when the HPV is negative, there is a significant benefit compared to HPV positive patients. There is no benefit in the HPV positive patients. So similarly, they have seen that stromal tumor infiltrating lymphocytes. So we can see here when the stromal tumor infiltrating cells is more than 1% in the tumor, so there is a benefit with this pan PI3K inhibitor. And similarly, when there is a intratumor CD8 expression is more than 5%, then also there is a significant benefit. And stromal CD8 expression more than 10%. Once again, there is a benefit of this pan-PA3 inhibitor. And the CD8 expression in the invasive margins, the cut margins or the tumor margins, CD8 expression more than 25% is then this buprasivir works compared to when the margin percentage is less than 25%. So it is predictive of when the TILS is positive, CD8 is positive, or P53 mutation is positive, and the HPV negative. So those cases, it is going to be more beneficial. These are the subgroup analysis they done in this group of patients. So coming on to one more target, that is inhibitor of apoptosis protein. So this IAP is there in the apoptotic pathway, and this will endogenously help in the tumor progression, actually tumor proliferation. Whenever the apoptosis protein is blocked, we know that cell death will not occur, and there is the cancer cells are mastered in having more level of this IAP antagonist. So one of the endogenous antagonist is SMAC. That is, we call it as a secondary mitochondria activated caspase. So this is the endogenous antagonist. So whether some of the mimickers they have identified, we call it as a Xavina-PAN. So this is the endogenous, synthetic, prepared IAP antagonist. This is the IAP antagonist. So inhibiting the inhibitor of apoptosis proteins, so that will prevent the proliferation or progression of the cancer cell. So one of the drug they call it as a Debio 1143. It is still in the research molecule, and they have seen that it has a radiosensitizing effect. So this is the before the radiation, and with increasing the radiation dose. So they have seen that with concomitant administration of this drug and increasing the radiation, 6 hour, 24 hour, or continuous treatment, or 24 post radiation, definitely there is a radiosensitizing effect of this drug, that is IAP protein inhibitor of IAP proteins. So it is a schedule dependent. So continuous you give, concomitant you give, there is a increase in the radiosensitizing effect of the drug on the tumor. So based on this only, they have done a randomized phase 2 trial with chemoradiation with cisplatin and this Debio 1143, and they have seen there is a significant benefit with this molecule. Progression-free survival as well as overall survival is improved. This is also a phase 2 trial where they have seen that addition of this drug to this cisplatin, there is a definite benefit. So coming on to promising targets with a companion biomarker. So one of these is a HRAS mutation. HRAS mutation, we see almost around 3 to 8% of the patients as per most of the retrospective literatures. So HRAS, for the activation of the HRAS to increase the proliferation of the cells, they require activation through the membrane. So farnesyl transferase is the one which activates this HRAS. So inhibiting this, so we will prevent the HRAS activation, and thereby decreases the HRAS, cell proliferation and the cancer cell death. So one of the drug is tipaferenib, so which is tested in the clinical trial. So we can see here in preclinical activity of this drug, the above the violet and blue line and pink line indicates in the wild type. HRAS wild type, there is no benefit, but in HRAS mutated, that is the green line indicates that there is a definite response for this drug in the patients with head and neck cancer. So this is the phase 2 trial where they have seen the objective response rate of around 55% with PFS of 5.6 months and overall survival of around 15.4 months. This patient has got benefit. Is definitely a promising target as per this phase 2 trial, and phase 3 trial is still ongoing. So other for antibody drug conjugates, though it is not still in the clinical trial, these are the list of drugs which are still in the research protocol. The different. So one of the drug, I think most probably we use it in a sacituzumab govitecan scan in the usually breast cancer patients. So apart from that, most of the this antibody drug conjugates we are not aware. So these are the drugs which are being tested in the clinical trial in head and neck cancer. So beyond single targets, whether is there any use of vaccination? So vaccination, we all know whenever the tumor burden is very low, then the vaccination is going to be more effective. Similarly, we can see in the prostate cancer, we have one vaccine, prostate vaccine. So similarly here also they have seen that TG4050. Personalized therapeutic vaccination, it is still ongoing phase 1 trial. So one of the this same vaccination where they have seen that used in rising CA125 with ovarian cancer, you can see here study entry where there is increasing CA125 levels, and still there was no lesions on the CT scan or the PET CT on imaging. Asymptomatic relapse confirmed, and they have given the vaccine induction. So post that there is a decrease in the CA125 levels, and CT scan being normal. So these are the things which are coming up in head and neck cancer in a big way. And so beyond head and neck cancer, we have most of the cancers will have a molecular tumor board. Similarly, the molecular tumor board, I think in another few years, it may come up in head and neck cancers where we will be discussing KRAS, NRAS, HRAS, PA3K inhibitors. So these are very important platforms we use using either the liquid biopsy or the tissue biopsy, where we have to decide on the typical targets for head and neck cancer, similar to most of the things we discuss in the lung cancer. So identification of potentially actionable targets are already there. NTRK, ALK, ROS, FGFR, activating mutations, amplification, signatures. So NTRK is one where larotrectinib, which can be used in almost all the cancers, which if it is positive, though it is the percentage of incidence is around 1 to 2% in most of the cancers. So conclusions, promising new targets include inhibitor of IAP and PA3K that are targeted without molecular selection. So as we have seen that PA3K, though it is activated, the success depends upon the subgroup HPV negativity, P53 positivity, and CD8 expression. So this PA3K inhibitor definitely is going to be one of the selection for our clinical practice. The only target to date to be targeted with a molecular selection is the HRAS mutation. And ADC is likely to be the next class of drugs in HNCC, and personalized vaccination may be a future of precision medicine. So molecular tumor board definitely is going to be a future along with the clinical tumor board in most of the cancers, including the head and neck cancer. I think I will conclude my study, my presentation.
Thank you so much, Dr. Srinivas. Now we'll move on to our next speaker, Dr. Suresh Babu, MD, DM Medical Oncology, Kidwai Memorial Institute of Oncology, Bangalore. And he's going to speak on ESMO Highlights 2022 in Head and Neck Cancers. Thank you. Over to you, sir.
Thank you, Priyanshi. I want to thank organizers for the opportunity. Just share my screen. Can all of you see my screen? Okay, thank you. So I'm just going to go through it. Yeah. Just see.
So do you want Priyanshi to share the screen?
I'll just.
Yeah, it has come. Perfect.
Okay,
you can make it full screen. Yeah.
Okay. Thank you. I just want to go through the some of the highlights which were presented in ESMO this year regarding head and neck cancer. So the outline of presentation is the squamous cell carcinoma, precancerous lesions, what is happening, what are the trials which we see in locally advanced head and neck cancer, and some things about recurrent salivary gland tumor and nasopharyngeal cancer. So this is one of the very important study. I thought, the precancerous lesion, we really don't have any treatment options for the precancerous lesion, especially in head and neck cancer to treat. This was one of the very important study which was done, where they gave nivolumab 480 mg IV monthly for 4 doses in a patient who had oral leukoplegia. They included the patient based on a 2-3-4 rule. 2-3-4 means they defined now precancerous lesion as a multifocal lesion which are more than or equal to 2 in number, or contiguous lesions which are more than or equal to 3 centimeter, or a single lesion which is more than or equal to 4 centimeter, which among which at least one lesion should have shown any degree of dysplasia. So to these lesions, they gave nivolumab 4 doses, 480 mg monthly. And their primary endpoint was the regression of the lesion. Secondary endpoint was safety, tolerability, and time for next head and neck surgery, cancer-free survival, and overall survival. When they saw the result overall response rate was around 36%. The other very important thing was that the PD-L1 status really never mattered to them, and the cancer-free survival probability at 2 years was almost about 78%. So this study did show some positivity in a precancerous lesion. Probably immunotherapy, when you give in a precancerous lesion for some time, it may delay for progression into a proper invasive head and neck cancer. But however, authors concluded that this requires further evaluation in a large scale to see whether this is going to work or not. The locally advanced head and neck cancer, one of the important trial was the Keynote 412, where we know chemoradiation can be a standard of care in a locally advanced head and neck cancer. They included locally advanced T3, T4, or any N2A, N3 larynx, hypopharyngeal, oral cavity cancer to this study, and they gave high dose cisplatin-based concurrent chemoradiotherapy. Along with cisplatin, they included pembrolizumab. Along with concurrent chemotherapy, they gave pembrolizumab, and also they gave maintenance for about 14 cycles. Treatment were continued until the progressive disease or intolerable toxicity, either 17 cycles of pembrolizumab or placebo. And investigator were given the freedom to withdraw from the study or not. Primary endpoint was event-free survival. Secondary endpoint were overall survival and safety and tolerability. When they saw the event-free survival, actually there was no much difference in the group. If you see pembrolizumab or placebo with concurrent chemotherapy, the event-free survival and overall survival was almost the same. But however, when they looked into the patient who had combined positive score of more than or equal to 20, they found that there was a difference. So pembrolizumab did work in a patient who had CPS score of more than 20, where 36 months of event-free survival was 66% in pembrolizumab, around 57% in that of the placebo arm. And overall survival there was a difference of 6% at 3 years. So in a patient who had got CPS score of more than 20, they thought that this could be a drug can be used. However, the conclusion was this was a negative study. They told that pembrolizumab in concurrent CTRT can be utilized as a treatment in a selected population. However, this thing to be investigated in a bigger trial than this. So there were also discussion about where to use PD-L1 in a locally advanced head and neck cancer. So should we use a better selection criteria like previous study we saw based on the CPS score, or if there is any other biomarkers? Can we spare radiotherapy on regional lymph nodes? Are we failing in sequencing properly the immunotherapy? So there were many abstracts were presented regarding the same. There was also discussion about the new drug called Xevinapant, which I'm going to discuss in the later studies. So this is one more study where they used nivolumab as a neoadjuvant before concurrent RT in HPV positive oral cancers. They received 2 cycles of nivolumab before starting the patient on concurrent RT. These were all the patients who are HPV positive oropharyngeal squamous cell carcinoma. So patient received the 2 cycles of nivolumab followed by concurrent RT. The reference arm received concurrent RT. The radiotherapy which was given was 70 gray IMRT for 7 weeks. Cisplatin was given 100 mg per meter square 3 weekly. At least 3 doses have been given in this study. If you see the treatment course, almost every patient received the nivolumab infusion, and hardly there was any deviation of the protocol either from the RT or from the cisplatin dose. A patient really tolerated well. However, the numbers were very less. In experimental arm, it was 41, and control arm, it was only 20. If you see the 1-year progression-free survival, there was hardly any difference between the 2 arms. Ultimately, the authors concluded that this is a negative study. Giving neoadjuvant nivolumab before the concurrent RT did not help the patient in locally advanced head and neck cancer. It had no any impact on event-free survival. It is one more, this is a phase 2 study where chemoradiation was combined with a drug called xevinapant. Xevinapant is a drug which is tend to act as a IAP inhibitor. Basically, this drug, what it does is it is try to bring the cancer cells into the apoptosis pathway, thereby the cancer cells are killed better. And this drug is being given as the oral syrup. So they included the patient who has unresected locally advanced squamous cell head and neck cancer, stage 3, 4A and 4B. This patient had a smoking history of more than 10 pack years. Along with cisplatin with IMRT, they added xeviplant in experimental arm. Of course, the other arm had the cisplatin with IMRT with placebo. The primary endpoint were local recurrence rate at 18 months from end of the concurrent RT. The secondary endpoint were PFS, overall survival, safety, and duration of response. If you see the progression-free survival, it did show a significant survival benefit. At the 3 years progression-free survival, almost it was double in the xeviplant arm compared to that of the standard arm. So they thought that the xeviplant could be a next drug which could be helpful in such patients. If you see overall survival also did come out with a very significant difference. At 5 years, the xeviplant arm had almost 53% survival compared to that of the 28% in that of the in the standard arm. So ultimately, authors concluded that this is the drug which is going to be watched in the future. They are doing phase 3 studies in a large scale to come out data regarding this. However, we have to wait till the data comes as a mature. Recurrent or metastatic keynote 048 is one of the study where they used pembrolizumab. This study basically had 3 arms. One arm was pembrolizumab was used as a monotherapy. Other arm had pembrolizumab in combination with chemotherapy, where they used cisplatin 5-FU. In some cases, cisplatin was replaced by carboplatin. The third arm was the same arm like extreme study, where cetuximab was combined with cisplatin or carboplatin along with 5-fluorouracil. So in the pembrolizumab, they are given up to 35 cycles. In pembrolizumab, but chemotherapy arm, after the 6 cycles of chemotherapy, pembrolizumab was continued. Extreme arm, we don't know. After 6 cycles of chemotherapy, cetuximab has continued as a maintenance therapy. Primary endpoint for overall survival and progression-free survival. Secondary endpoint was overall response rate, safety, and duration of response was the exploratory endpoint. Overall survival, if you see in intent to treat population, compared to pembrolizumab single arm to the extreme pembrolizumab single arm did have a better overall survival. Almost the difference was almost the difference was almost about more 8 to 10%. Even if they compared pembrolizumab with chemotherapy arm, this arm also did better than that of the extreme arm. So thereby, in the trial, pembrolizumab did help in a head and neck cancer patients when compared to that of the cetuximab in this study in a recurrent or metastatic group. So this is again The same study which is showing overall survival was much better in a patient with CPS score of more than 20. As we saw the previous chart, it was it was helpful irrespective of the CPS score. But when they tailored to the CPS score, the benefit was much more better. What was seen in the patient in a intention to treat population without CPS score. So thereby, pembrolizumab in head and neck cancer worked irrespective of the CPS score. But however, the benefit was more in a patient who had CPS score of more than or equal to 20. This is Keynote 040 pembrolizumab, which is used as a second line after platinum therapy. Here also pembrolizumab did work in both intent to treat population or patient who had CPS score positivity. However, when the patient had a score of more than 1% of CPS or TPS of more than 50, the benefit was much more compared to that of the intention to treat population. So pembrolizumab did work in a recurrent or metastatic setting, either used as a first line or used after platinum therapy. The benefit was there with the pembrolizumab. This is Keynote B10 trial. The Keynote B10 trial was basically done to see whether pembrolizumab can be combined with other alternate options like paclitaxel and carboplatin. Remember, pembrolizumab was basically approved in combination with cisplatin and 5-FU. This trial was basically try to look into that. Can this option be an alternate option if for some reason patient is not able to tolerate cisplatin or 5-FU based treatment? So again, previously untreated head and neck cancer, oral cavity, oropharynx, larynx, and hypopharynx were included in the study. Pembrolizumab, almost up to 35 cycles were given in combination with the paclitaxel and carboplatin, which was given for about 6 cycles. They followed the patient up to 35 cycles after the treatment. B10, if you see the response, overall response rate was almost about 42%. About 5% did achieve CR, and the partial response was seen in about 38% of the patients. Stable disease in about 30% of the patients. So there was a good response. Duration of response was almost about 58.5 months. If you see the Keynote 048 and B10 study, the pembrolizumab did help in both the cases. One of the very important things which we saw in B10 study was that even the CPS score was less than 1, the response was very good. However, this was not the message the authors wanted to conclude. Authors concluded that if a patient for some reason is not fit for the cisplatin or 5-FU based treatment, then carboplatin paclitaxel in combination with pembrolizumab could be alternative. It is non-inferior combination which you can use to treat such patient. That was the conclusion of the authors. Salivary gland tumors, we know salivary gland tumors are very rare and quite difficult to treat, and they do come with a variant histologies. So this was the study we tried to look into, is there any targetable genomic alterations they could find in various histologies of PIK3 and red BRCA2. So there were various targetable lesions which were there. But however, among this, the very important thing they found was that the secretory salivary subtype of salivary gland, which is a very, very rare subset of salivary gland tumor, it did have a gene fusion of ETV6 with NTRK3 gene, which was seen in more than 80% of the cases. So there was a drug called as larlotinib, which can be used in this gene fusion, which is particularly seen in this rare subset of salivary carcinoma, secretory carcinoma of the salivary gland. What they found was objective response rate was almost about 84%. Median progression survival was about 56%. So in the rarest form of salivary gland subtype, when they found some genetic marker, they could use a drug and could make a difference in the survival. So they ultimately concluded that when you find a rare tumors in salivary gland, you must look for some target lesions. If you find a target which can be treated, which can make difference to that of the survival. That was the conclusion of the study. Nasopharyngeal cancer, Vence trial is one of the trial which was looked into the nasopharyngeal cancer. Epstein-Barr virus nasopharyngeal cancers were taken into the study. More than 18-year-old, either metastatic or locally recurrent, which were not available to any further curative chemoradiation or surgery, with good performance status were taken into the study. At least minimum of more than 6 months since last chemotherapy or adjuvant immunotherapy should have elapsed before enrolling into the study. They included the patient and subdivided into 2 arms. First arm, arm B received gemcitabine with carboplatin with palliative intent. The arm A received the chemotherapy along with the combination of the virus-specific autologous cytotoxic T cells. So these were the cytotoxic T cells which were given along with the gemcitabine carboplatin. In the A arm, they received 4 cycles along with the 6 cycles of the T cell infusion, whereas the arm B, they received 6 cycles of chemotherapy. The endpoint were overall survival. Secondary endpoint were 2, 3, and 5-year overall survival. Progression-free survival, overall response rate, and safety profile was the secondary endpoint. Overall survival, if you see, it didn't make much difference. Infusion of these cells along with the palliative chemotherapy didn't make any contribution to the survival. So ultimately, they concluded this study as a negative study and they closed the trial. So the take-home message was in high-risk leukopenia, we saw that nivolumab or there could be other immunotherapy drugs which could be worth, but they need to be further investigated because we know this, precancerous lesions, which we are very difficult to treat. We require to keep the patient under very vigilant follow-up. In a locally advanced head and neck cancer, xevinaplant is a very promising drug. It is currently investigated in phase 3. Pembrolizumab might benefit in the patients who have got CPS score of more than 20, but other than that, it didn't show much benefit in a upfront setting in a locally advanced head and neck cancer along with chemo-RT. In recurrent and metastatic setting, we know that 5FU platinum, pembrolizumab is a very good drug to be treated. Carboplatin with combination with paclitaxel in pembrolizumab could be an alternative to this combination if we if we have any time contraindication to 5FU based treatment for any reason. In a recurrent or metastatic salivary gland tumors, or for that matter, any rare tumors, NGS need to be done to identify if there are any targetable genomic alterations so that can be altered and we can give treatment based on that. Recurrent or metastatic nasopharyngeal cancer, there doesn't seem to be any much change in the first line treatment. Concurrent CTRT remains the standard. In a metastatic, we have to give palliative chemotherapy. However, immunotherapy has not shown any much benefit in this case. Thank you.
Thank you so much, Dr. Babu sir. Immunotherapy is slowly making inroads and coming into the early leukopenia also. In future, we don't know where it will take. It is a difficult job to summarize everything. Now I will request Dr. Jyoti Wadhwa, madam. Dr. Jyoti Wadhwa is Senior Director of Medical Oncology, Medanta, the Medicity Hospital, Gurgaon. Madam, over to you for take-home message.
Thank you, Mr. Rajesh. And I'm sure all the participants would agree that today's masterclass on head and neck cancer was a very fruitful one. And we all would agree that we all benefited from the 4 presentations made today. So my job is a bit tough, but I'll try to simplify what I have learned from these 4 presentations. So the first one dealt with the clinical applications of multi-omic profiling in head and neck cancer. And we know that multi-omic profiling for cancers does provide a better understanding of the disease and helps us to better choose the treatments for improvements in not only quality of life, but also quantity of life of patients with cancer. Out of the various multi-omic profiling types, the genomics and transcriptomics are already well established in clinical practice, and they are currently being used to guide the treatment decisions, such as prediction of drug efficacies and selecting patients for, say, PD-1 blockade for our patients with head and neck cancer. The second presentation was about circulating biomarker assays in individualizing targeted therapy and immunotherapy for head and neck cancer patients. And in this talk, we learned about the evolving role of circulating tumor DNA in not only locally advanced head and neck cancer, but also recurrent and metastatic head and neck cancer. However, I would comment here that the data for these 2 indications is still limited. What was presented is that for locally advanced head and neck cancer,
This is being used to monitor the minimal residual disease after the patients have completed the curative intent treatment. And it is also being used for surveillance of cancer recurrence after the patients have been treated for locally advanced head and neck cancer. For recurrent and metastatic head and neck cancers, it may be used to monitor response to treatment. So somebody has shown some response or no response. One could use the circulating tumor DNA to monitor the depth of response or the degree of response to the treatment. In such a setting, it could also help in identification of various treatment targets or elucidation of the resistance mechanisms. The third presentation was about the newer promising targets on the horizon in head and neck cancer. And this was the most complex. There are four categories of the so-called promising targets. One without companion biomarkers, in which PIK3CA mutation and PIK3CA amplification are emerging in a big way, and also the identification of TP53 mutations. The second category of targets is the one with companion biomarkers. So in this, we have a molecule, tipifarnib, which seems to help patients with the HRAS mutation. The third category of promising targets deals with the antibody drug conjugates. However, there are only phase 1 studies available till now, and the overall response rates in all these studies have varied from 0% to 40%, so highly variable. We don't know what the future holds for the ADCs for head and neck cancer. And the last and the fourth category was the others, wherein personalized therapeutic cancer vaccines are under study in phase 1 trials. So this talk signifies the importance that molecular tumor boards hold, wherein we could discuss some of these identifiable targets and offer newer treatments to our patients with head and neck cancer. Now, the last one by Dr. Suresh Babu presented some very interesting and very relevant data presented in the ESMO 2022 on head and neck cancers. Very interesting was the efficacy that nivolumab showed in terms of regression of the high-risk leukoplakia. So if we could prevent head and neck cancers, there could be nothing better than that. Then coming to the locally advanced head and neck cancer, he presented two important abstracts. One dealt with the use of pembrolizumab with chemoradiotherapy followed by maintenance pembrolizumab. And this did seem to work, especially in patients with the CPS of 20 or more. However, this was post hoc analysis. The other study that he presented was of chemoradiation with xevinapant, which is an oral small molecule inhibitor. And this did result in improvement in progression-free survival as well as the overall survival. Now, coming to the recurrent and metastatic head and neck cancer, what he showed were the two important studies related to pembrolizumab. The Keynote 048, the improvement in the median overall survival to as much as 14.9 months, especially if the CPS score is 20 or more, with pembrolizumab alone or pembro with chemo when compared with the extreme regime. So the pembrolizumab does improve the outcome in terms of improvement in the overall survival. Now, very often we are not able to use the 5-FU platinum combination with pembrolizumab. And herein we have Keynote B10 to our rescue, which showed that pembrolizumab does seem to work even with paclitaxel and carboplatin, which we often tend to choose in our clinical practice. So the response rates of 42%. However, the OS data is still pending, and we would be waiting to see the survival data. So this combination of pacli with carboplatin with pembrolizumab may be an alternative to the 5-FU pembro with platinum, as per the Keynote 048 trial. And he also dealt with the secretory salivary gland tumors, and larotrectinib found to show some improvements there. So very interesting research happening very fruitful outcomes, some already reported and some more awaited. So thank you for giving me this opportunity to be part of today's masterclass on head and neck cancer. Thank you. Over to you, Rajesh.
Thank you very much, ma'am.
Thank you, Mr. Om.
Thank you, madam. Thank you, everyone.
Thank you to Dr. Satish. Thank you to Dr. Suresh Babu. Thank you to Dr. Shruti Behel for taking out your valuable time. And I'll say a heartful thank that Samarth will be dedicated and will be continuing and bringing you such master classes in future also. And Dr. Srinivas has given a very good talk also. And thanks, Rajesh, for taking out your time with your busy schedule as he is in Chennai for the conference. And thank you, Dr. Jyoti ma'am, once again for summarizing, which is a very tough job for you. And with this, Rajesh, I think so we should call off the day.
Yes, we can call off. Thank you.
Everyone. Thank you.